everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. I'm here in New York City at the International Spinal Deformity Symposium. I'm joined on the panel today by some of the directors of this program. At the National Spine Health Foundation, our mission is to educate the public about spinal healthcare. Our premier educational platform is Spine Talks. Today's Spine Talks brings you unparalleled access to these world-class experts from our medical and scientific board who represent the top 50 surgeons in America. It's my pleasure now to introduce Dr. Tom Schuler. Dr. Schuler is the CEO of Virginia Spine Institute and is the chairman of the medical and scientific board. Tom?
Thank you, Rita. We're so excited to be here in New York and learning from these incredible experts. I'd like to introduce you to our panel. First, we have the chairman of the course, Dr. Larry Lenke, past president of the Scoliosis Research Society and one of the professors at Columbia University and surgeon-in-chief. We have Dr. Serena Hugh from Stanford. She is the chief of the spine surgery section of Stanford, and she's also an incoming president of the Scoliosis Research Society and current president of the American Orthopedic Association. And Dr. Ron Lehman is a professor at Columbia also, and he is chief of spine surgery. So we're delighted to have these experts who can talk to us about the complex issue of spinal deformity. So to start, we need to understand what deformity is, but before we do that, let's talk about normal anatomy. So Larry, and I gotta love Larry, he's one of my classmates from Notre Dame.
There you go. A while ago.
A few years ago. Right. But Larry, let's talk about what's normal anatomy so we can then lead to deformity talk.
Right. We have to understand what is normal in the spine before we can just understand what's abnormal. We evaluate the spine from the frontal view and from the side view. From the frontal view, the alignment is fairly easy to understand. It should be straight, bottom line. Our spine should be straight from the base of our neck all the way down to our pelvis. And so any deviation or a curvature that occurs in the frontal plane will be designated as some type of deformity.
So that'd be something shifting to the right or to the left?
Exactly, either way. But it's deviation from the midline of the body, basically.
Okay.
From that perspective. It's more complicated from the side view because there are normal curvatures of the spinal column when you look at the spine from the neck all the way down to the pelvis.
And what are those normal curves?
So the normal curves in the neck basically is what's called a lordosis, or a curvature that basically kind of rests your skull or head on your shoulders. And then a reciprocal kyphosis, which goes the other way, bending basically your thoracic rib cage region. And the reason we have a bit of a curvature there is to allow for increased room for your heart and lungs to sit in that area. And then below that, to keep us balanced, we have another lordosis curvature in the lower or lumbar spine going into your pelvis. So kind of three curvatures, two in what's called lordosis, and one opposite going in kyphosis, they basically keep, again, your head centered over your pelvis.
Right. So the spine's straight in the front, but from the side it curves to the front, then to the back, then to the front.
Exactly, right.
So
in a normal alignment, normal person.
So Serena, what is deformity then? When we talk about deformity, I know it covers a lot of areas, but how would you describe that to the public?
When you describe a spine deformity to the public, it would basically be a deviation from the norms that Larry just talked about. So in the frontal plane, again, something that's not straight. So if there's a curve to the right or to the left, or if the person is leaning one way or another, those would be considered curves or scoliosis for the most part. If you have a deviation on the side view, okay, where Larry described that you normally have three curves, you can have too much curve in an area, or too little curve in an area. And both of those can lead to problems with standing properly or potentially give people back pain, and we call those spinal deformities.
Ron, why is spinal deformity an issue? Why do we even care about it?
One of the important things to understand about what we call spinal deformity is it's not normal. But we're all essentially not normal. We all have different things, and so what could be normal for one person may be not normal by the textbooks, but it's still, quote, normal, and we can function the same. What it really becomes an issue is when patients start having pain, or they start having pinched nerves that can cause symptoms in their arms or legs, numbness, weakness, tingling, things like that, and those are where sometimes it can become problematic, or if the curves are very large. And so sometimes when curves are very large or very big, they can sometimes squeeze in the heart and squeeze in the lungs, or they can squeeze on some of the nerves in the low back, and then it can become a problem because it really brings about what we call disability, or patients or people can't function as well. And that sometimes requires different types of intervention.
So, Larry, if somebody's just slouching, is that deformity? Or if they're just kind of always lean one way, is that deformity?
Yeah, in the truest sense, slouching or leaning is not a deformity per se, but it is an abnormal posture. And that's where I think we have to differentiate these kind of regional aspects of deformity or regional malalignments of the spinal column versus global malalignments, where basically the whole trunk is leaning either to one side or forward or back, or I mean, there's any type of postural malalignments. And some of those are structural and some of those are non-structural. And so there's different deviations of that, determining basically how much disability my patient have. We'll kind of go back to what Dr. Lehman said, is that a lot of patients who have some deformity really don't have any problem with that, any disability, and so there's no reason to even really seek medical care potentially.
So they can live their life in spite of not being lined up normal.
As Serena mentioned, some people have a little bit more, maybe hunchback or kyphosis, but that's kind of their normal. It's not a there's no disability with that. That's kind of the way their spinal column kind of was meant to be, and for most of their life, they will probably be okay with that. Obviously, as we age, degeneration and arthritis can occur, and that can take an otherwise slightly deformed spine into an element where it will become disabled for them, provide some disability for them. So it really depends on not only the type of malalignment or deformity, but also the age of the patient, and again, their baseline level of ability or disability.
Okay. So we're talking predominantly here about adult deformity.
Right.
And so, Serena, what constitutes adult deformity? What age did you become an adult that you have deformity?
Well, strictly speaking, it's at age 18. So that's how we define it medically, and I think most people understand that you become an adult at age 18. And the other thing that I think is important to point out is that not only do we all have aspects of deviation from the norm that are perfectly acceptable, but we compensate for them well. You know, if you've been kyphotic or more hunched over for much of your life, that's what you're used to, that's what you compensate for. But as we get older, as our joints and discs become degenerated, it's possible that you could become less able to compensate for those. We might be less fit and less strong, and again, less able to compensate for what's been our baseline through much of our life.
So, Ron, does bone strength, bone density, does that impact anything with deformity?
Yeah, certainly bone strength is incredibly important, especially when we look at the older patient. You know, as we all age, our bone becomes thinner, and it's more important in certain patients. Certainly adult women who are a little bit older have a little bit more issues with what we call osteopenia, which is where the bone gets thinner, and then osteoporosis, which is more commonly known, is when the bone is sort of really thin or not as strong. And so if you do have some type of deformity in your spine, either you're bent too much to the front, the kyphosis we talked about before, and you have soft bone, it may make it a little bit worse. In addition, patients can get fractures. They can get fractures of the spine, fractures of their hip that are also not uncommon when your bone becomes soft, with terms like osteoporosis that you hear a lot in the literature.
So let's talk about treatment. I mean, spine surgery has evolved so much over the past several decades. What is the current state of surgery in correcting somebody's scoliosis or their flat back deformity or their spondylolisthesis, some of the common terms that we hear out there? So what innovations are happening, and how do we approach treating these surgeries today that we didn't used to? And I'd love to hear from all three of you on this.
Honestly, I'd first like to say that, well, let's talk about non-operative treatment, because by far the vast majority of patients with any type of adult deformity, adult spinal deformity, won't need surgery. Right? They'll need an assessment potentially, especially if they have, again, any type of disability. But the vast majority of patients will have more mild deformities that require things like physical therapy, bone health and osteoporosis prevention aspects, and even with pinched nerves and things can have steroid injections and other non-operative treatments that are very common in even the degenerative spine population. So I think we should really emphasize that. The vast majority of patients that have adult spine deformity will never have to see a surgeon for any type of surgical intervention.
Yeah, that's critical. What estimate would you say percent of people with adult deformity issues end up needing surgery, Serena?
That's a very hard
Do we
number
know?
to
I don't
come.
know if we know that.
I don't
right?
think
'Cause,
we know that
yeah.
exactly. I
It's
think
hard to know the denominator of that. How many
exactly
patients
because a lot
actually
of
have.
people are fine.
But it
with
would be a small percent.
You know,
a
so
small percent would
yeah.
actually need surgery.
Exactly.
Right.
That's my
Actually,
point.
yeah. Yeah. So
But-
it's we don't know what the denominator is because most people don't need to come to our offices to see them. You know, they don't usually come to see us as, you know, kind of surgeons until either somebody says, "Oh, you should see a surgeon," or they're like, "Oh, wait a second here, this is getting worse," or "I'm less able to compensate for my disability by going to physical therapy or
Well, I
staying
think
fit."
that's a great question. Is oftentimes people don't know when it is time to see a surgeon, and often it's the surgeon who can say, "No, you don't need surgery," to make that determination. Let's try some other non-surgical treatments, and that maybe it's best that they hear that from the surgeon.
I think that's something that's really important that you bring up, that if you learn or you know that you have a spine deformity, whether it be scoliosis or another malalignment, to see a surgeon so that you know what to watch out for, how to take care of yourself to try to avoid surgery, is better to get education early and learn about the bone health and learn about the fitness and things like that to try to avoid, because like we said, most people don't need a surgeon.
Right. And part of what we've found in doing these Spine Talks conversations is that there's a spectrum of care, right? And surgery being at one end, but it's the spine surgeons that really understand the entire spectrum. Whereas if you're seeking treatment somewhere, you may not get the full picture, from the advice that you're seeking. Whereas, we've seen that the spine surgeon can explain to the patient the entire road, what that roadmap looks like, and figure out whether or not surgery is the right thing for them.
Right. That's an important point because obviously, surgery should be the last resort for patients that have enough disability and enough deformity to warrant it. But there is a process of education to our primary care providers and even our non-operative spine providers realize that some of these patients actually can be helped by surgery when appropriate. And it's not too infrequent that I see a patient who basically was told for years and years and years by other either physicians and obviously not often not even spine surgeons that there's nothing that people can do for you. Surgeons cannot help you, so don't even seek their care. And then they ultimately see us sometimes at the point where they're now too advanced age to be benefit from the surgery.
Yeah.
So there's still a lot of education that needs to be performed, not only the patients but even our internists and our other medical providers across the country.
It's so amazing to hear that from you, Dr. Lenke. I think a lot of times there's a stigma. Right. Avoid surgery at all costs. Like, don't have surgery. And there's reasons for that. But I think there's so much good news in spinal care, and that's what we're talking about today.
Maybe I'll ask Ron. We know we have some pretty good data now. I mean, what is the value of non-operative care in patients that have true disability and a known progressing spine deformity? We have good data now. What is the outcome of non-operative care for those patients?
Yeah, I mean, I think a lot of it is, the patient and the person really dictate, their care. And so we talk about things being normal or abnormal, people having curvatures, but it really comes down sort of to how much it affects you. And I always tell patients, when I see them in the office, that I ask yourself sort of two basic questions. If you tried a lot of the non-operative things like physical therapy and medications and maybe injections, is do you think about it more than you don't think about it? And two, does it affect more of your life than it doesn't affect? And that's the time to maybe consider seeing someone like a surgeon, because we know that when patients are very, quote, disabled, which means it really affects you and affects how your life is, patients often do better with a surgery in that setting than if they don't have surgery over the long course of time. And we have many publications now that sort of speak about that. And so once you really maximize all of the non-surgical things to do, but it's still really bothering you, whether that's back pain, whether it's you're leaning to the left, or leaning to the right, or leaning to the front, or you have leg symptoms, numbness, weakness, tingling in your legs that just isn't getting better despite trying all these things, that's the time to maybe certainly see a surgeon and consider, is that option the best for you as an individual?
So that, really important. Don't have surgery if you don't need it, but we need to understand what's available. Let's get to the point now. Let's talk simple. A spondylolisthesis. What minimally invasive techniques are available today to solve that minor deformity that can give people their lives back?
But what is a spondylolisthesis?
Sure. Spondylolisthesis.
Just don't ask me to spell it, okay?
Yeah. Spondylolisthesis is slippage of the spine. Spondy is spine. Listhesis is slippage. So it's a forward slippage of one vertebra or one bone on the one below. Typically, we're talking in the low back. So if somebody comes into you and they have a spondylolisthesis, they failed non-operative care, what treatments do we have today on the level of the simplest deformity out there?
Yeah, I think it's a great point. Certainly patients that have the slippage oftentimes will get physical therapy and will get an injection. And injections really sort of help to target to make sure that if you have a huge benefit and a response to the injection, meaning you get an injection and it really helps your pain even for a couple days or a couple weeks, we know that that's really causing your symptoms. And oftentimes with the slippage, we get compression or pinching of the nerves, and that can lead to leg symptoms. And so in those patients, there's a lot of different opportunities now and things that are really continuing to advance quite quickly. In general, when we talk about surgery for the slippage or the spondylolisthesis, we basically use pedicle screws, which are screws that go into the bone to help keep them stable so they don't move anymore and don't slip anymore.
Into the vertebra.
Into the vertebra or the actual bone itself.
Right.
And then we also take the pressure off the nerves in the middle and on the side so that when we're done, we know that the pressure has been alleviated, which should help your leg symptoms. We know that we put the screws into the bones or vertebra to help stabilize it, and then we add rod connectors in the back to make sure that they don't move any further. And there's many different ways we can do that. A lot of these techniques are less invasive, so we can use things like robotic assistance, or we can use a navigation, which is like a GPS system that you would use in your car to get from point A to point B to make it more safe and more reliable. We can use small incisions. We can not disrupt the muscle as much. So all these things allow for quicker recovery. And now we have great pathways in terms of recovery as well. So we call it ERAS, which sometimes you'll hear here, which is enhanced recovery after surgery, meaning do we do physical therapy quicker? How do we get you back to work? How do we get you back to function so you can get back to live your life and do the things that you want to do because this problem's been so difficult for you for such a long period of time?
So Serena, with the minimally invasive techniques out there for somebody who has one level spine problem, spondylolisthesis, because we're talking about deformity, and it gets fixed appropriately by a good surgeon, what's their ability to return back to life?
Well, and that's one of the nice things about the advancements we've had is that the majority of people can go back to do virtually everything they want to. Not everybody has a perfect result, but most people can go back to doing what they did before this started becoming a problem, before it started limiting their activity and things like that. So that's one of the very nice advantages. So if a person has developed increasing limitations because of their spine condition, whether it be spondylolisthesis or a scoliosis or a kyphosis or a flat back or any of the other terminology we'll be using, we can oftentimes get the patient close to, if not to, their pre-disability, before they started limiting themselves.
And I think that's a great point and something that the public needs to understand. I've been in practice now for 30 years, and I can tell you when I started my practice, it was not too uncommon for my colleagues who we called kind of dabbled in spine surgery, or orthopedic surgeons who did a little bit of spine surgery one day, the next day maybe they did hip surgery, the next day they did foot and ankle surgery. So you did kind of a gamut of the spectrum of orthopedic surgery. But now in the last 30 years, it's really become a fact that spine surgeons specialize only in spine surgery. And guess what? With that, spine surgery has better outcomes now because the surgeons are focusing on one condition, right? And the reason that is essential is that 30 years ago, the results of spine surgery weren't as reproducible. The results weren't quite good, and the term failed back syndrome of failed back surgery really was quite prominent and prevalent back in the 70s, 80s, and even into the 90s. But obviously, again, as Serena mentioned, nothing's 100% or 0%. We can't guarantee a perfect result. But the results are so much better now because the surgeons who specialize in spine surgery really pretty much only do that. And so they're focusing on that type of pathology every day, right?
Yeah, it's actually a great point. One of the questions we always get asked is, do I need an orthopedic spine surgeon or a neurosurgeon? And what I often tell them is, you need a spine surgeon. You need someone who only does spine surgery, doesn't dabble in this and doesn't dabble in that, but only focuses on spine surgery because like most things, if you do it every day and you do it routinely, you're going to do a better job.
Yeah, and these are people that have done fellowships in that, extending their level of training. And so, yeah, no, it's exciting. I mean, for me, treating one level fusions gives people their life back and they get back to full activity. And I've had people go back, play professional football, go back, be Rangers in the military. So it doesn't limit you. And I think that's a concept people get concerned about. They hear you're going to have a fusion, and is it going to end my life? Is it going to stop my mobility? We understand that there's 23 discs in the spine, and if we're fusing, we're taking one out, in this case of a one-level surgery.
And And
Yeah,
I'm
go ahead.
sorry to interrupt, but and the concept that Larry brought up about the failed back, those were patients who had fusions for wear and tear of their back where we didn't understand alignment. The failed back syndrome was applied to a person who had a fusion for a degenerative back problem where we didn't understand alignment. And
What's
so
alignment?
alignment
It's
is
critical, but what's help
no,
the
so,
public
so the
understand
alignment
alignment?
is what
Back to
Larry
what we
talked
said
about at the very
initially,
beginning.
right.
It's what's
Those
normal
curvatures,
alignment.
right.
When you get wear and tear in your back, your discs collapse. And so if the people get fused in a bad position, that's going to set up a cascade that's going to be bad for the spine. If you fuse somebody because they have a slippage, a spondylolisthesis, you're going to be fixing them so they don't continue to slip and potentially pull them back into better alignment. And that's going to be something that improves the alignment and has a much higher likelihood of successfully returning you to a normal life, as opposed to if you have an operation that's poorly done, which is how we didn't understand these things before. And that's a big difference from the standpoint of advancements we've had.
That's the huge development in deformity, treating spinal deformity. Is this proper balance, proper alignment, restoring those normal curvatures of the spine? And I think that's been the biggest change. Did you want to comment on that at all?
It's like the old commercial for the hair club for men. I'm not only a spokesman, I'm a client, right? And so over 3 years ago, I have a slippage or had a slippage, and Dr. Lenke actually did my surgery. And so I take the same advice, or took the same advice that I was giving to my patients for years. And once I started developing back pain that I just couldn't do the things I wanted to do anymore, and I got leg symptoms that it really affected me, and I was thinking about those, I knew it was time for me to have surgery. And so I had a spine fusion. I had 2 levels fused in the low back. And to your point about being able to go back and return to doing normal things, you can also be a spine surgeon after getting spine surgery, and you can do spin class, and you can go downhill skiing. All these things I do, and I was able to do them quicker than I think I even allowed my patients to do beforehand, but it gives me a different perspective that you can function at a very, very high level even after a spine fusion. Because what I tell patients all the time is if you do the right surgery for the right person for the right reason, you're going to have a great result. And that's much different than the failed back syndrome we used to hear about all the time, because they may not have understood as much as I think some of the advances that we have now.
Yeah, there's no question. Training's gotten better, education's better, the focus is better, and the technology's better. So all of these things are producing really phenomenal results. So we've talked about a simple problem such as spondylolisthesis at one level. Let's get into more complex. Let's talk about an adult person with scoliosis.
Sure. So again, this will invariably involve more vertebra, right? So a larger portion of the spine is going to be deformed. And so if it's, again, a progressive problem that's causing appropriate amount of disability that's failed non-operative treatment, often these patients, should seek a surgical consultation. And obviously there's a lot that goes into whether a patient is a good surgical candidate, and surgery will be recommended. But often it is, and for appropriate patients. And the good thing is that current technologies and understanding of and the processes involved in these surgeries, patients can still have a remarkably good outcome and lead a remarkably normal life, even after 8, 9, 10, 15 levels of spine fusion, and in some extreme cases. And that, again, just shows, I think, to the progress that has been made the last 2 to 3 decades in not only spine surgery, but even in the subspecialties of spine surgery, which includes spinal deformity surgery. I mean, I basically call myself a spinal deformity surgeon. That's all I've really done the last 20 years exclusively is spinal deformity. So spine surgery has not only become its own kind of subset of surgery and medicine, but even within that specialty, there's subspecialties now of people that focus on specific problems. And that, again, the more you focus your practice and you focus your energy on a specific area, you should get better at that area, right? And so that's what a lot of us have done. And that bodes well for future patients as we all become more focused in our practices.
So we're covering the spectrum of the country here from New York to California. Right. So what's exciting out in California?
The thing that I find the most exciting about spine surgery these days is, number one, is knowing what an individual's alignment should be, and also how much more safety we can do it with. Right. So between neuromonitoring, which Larry has done a lot of innovative work on, and minimally invasive surgery that Ron has done a lot of work on, and then kind of the pathways. So how do you prepare a patient for surgery to make it as safe as possible? We've gotten much, much better at that, rather than, oh, you need surgery here, sign up. But, oh, we need to make sure your bone is healthy, make sure your heart's healthy, make sure you're physically as healthy as you can be. And I think that helps the patient. And then afterwards, we have a better understanding. We don't keep patients in bed for 2 weeks or even a year. Before we had rods, we put patients in bed for a year. Can you imagine how disabling that would be and how destructive that would be to your, for all those things? But we get patients out of bed the next day or even that day. The day after surgery now. And they don't need casts, and we get them up walking. And that keeps them fit, and it lowers the complication rate. And we do this often enough that we have pathways so we know the patient should be doing X at this point in time. How can we make their pain management better? How can we make them breathe better so they don't have blood clots or pneumonia? So all these things, I think, allow us to do major correction if we need to, minor operations if we can get away with it, and then do it in as safe a way as possible. So that, I think, is really exciting, to do it safely for the patient.
Do you see with these modern technologies, robotics and navigation and minimal incisions, do you see people recovering faster than they used to?
Oh, definitely. Again, we used to do surgeries, you'd stay in the hospital for weeks because you would be stuck in bed, or you'd need extensive bracing or things like that. Getting people out of bed the next day means you get to go home that much sooner. And it means you walk again and go back to your life that much sooner.
And so they're getting out of bed because of the instrumentation and the ability to hold the spine. Is that a fair statement?
Yeah, it's partly that, and we're better at managing their pain and doing things efficiently.
And it's easier, but I'm worried about it. Our whole team is better. It's a system approach, right? Yeah. As I say, it takes a village to prepare, perform, and recover patients from these kind of surgeries. But almost all of our centers basically have those type of pathways and personnel involved to make sure that patients can prepare, have, and then recover from these surgeries appropriately.
And it's really something we've adopted from technology, right? So if you get your iPhone, every iteration gets better. Right. You type something and it knows your patterns, right? And so all of us are at centers. We do a lot of research with many different centers and hospitals throughout the country and world. And as a result, we just know better. Like Dr. Hugh was saying, we have things like we know where patients who get to the point where they may need surgery, what their normal position of their spine and body should be. We didn't know that as well 10 or 15 years ago. We also know what they should look like based upon how old you are, what your condition is, what your symptoms are. And so, no different than other things, we now have this ability to understand where we're starting, where we're going, and we have much better techniques to go from point A to point B. And that allows us to feel more confident that we have you in the proper alignment from the front and from the side, and it allows you to recover and do things and get back. And we also know, but I know from my own experience, I do things quicker than I was allowing my patients to. So now I use that information, and we all continue to do this stuff. And so it's all this machine learning and artificial intelligence. We have this ability to get, quote, smarter for each of us and really refine these pathways, like Dr. Hugh was saying, so it's more objective. And so we can say if you're in Nebraska or New York or California, you're going to have a pretty similar outcome if you go to a place where they do the surgery often and they understand where you're starting and they understand where you need to get to.
I'm going to ask you a little bit of a trick question here. Artificial discs. Everybody wants laser surgery. Everybody wants artificial disc surgery. What about artificial discs and deformity surgery?
Artificial disc and deformity surgery in general are usually not a great idea. So artificial disc surgery works very well in the neck or the cervical spine, much better than even in the low back. And what it does is it preserves motion, which is great. It has indications that are pretty similar when we talk about neck surgery or surgery in the cervical spine. But when a patient has a significant deformity, in general, we take the pressure off the nerves, but sometimes keeping motion actually continues to irritate the nerves after surgery and can actually make the deformity worse in some cases. So I think it's really important that each patient who has something, it's great that we all read and we look on the internet, we get a lot of information, and it's really sort of, I think, even good from an educational standpoint. We see patients who are very well informed, but I think once again, we all have to have an open mind and understand that for certain things and certain approaches are generally better, and sometimes technology, although it sounds great, and minimally invasive sometimes sounds great, but it may not be the best thing for you individually as a patient all the time.
That's maybe where the distinction between degenerative conditions and deformity conditions really needs to be emphasized. Artificial discs often work very well for patients with degenerative conditions of their neck or lower back.
What's that mean? What's degenerative?
Degenerative basically is aging of the spine, decreased disc height and water content of the disc spaces or the shock absorbers between the vertebra. where they start to collapse and cause arthritic pain, again, either in the neck or lower back, and again, with or without pinching of the nerves. It occurs with that as well, without any malalignment to this overall spinal structure. So
we're back
that's
to
the difference.
alignment. Alignment is the
So
key.
alignment is the key. So degeneration is going to occur. That's the process of aging. It occurs in all of us. Some patients age without malalignment, some age with good alignment, but just degeneration. And so if you have a degenerative condition that requires surgery, often that's a different surgical pathway than a deformity condition that requires surgery. That's the point.
So now I have to ask our panels, we're drawn to a close here. How do people find a spine surgeon who can deal with deformity? And I'd love to hear all of you comment on that.
Obviously, you can probably look at the Scientific Medical Advisory Board of this foundation, and you'll find surgeons who specialize in whatever condition you have. And that's, I think, one key now. As I mentioned earlier, spine surgery is getting very subspecialized. Whatever spine condition basically you have, you can probably find, if you live in any metropolitan area, surgeons, a group of surgeons that really focus on that kind of surgery. Are they the best for your condition? Well, I mean, you need to decide that. It's complicated, obviously, but at least it's much better than we were 30 years ago, where basically surgeons didn't really specialize in spine surgery. So we're in a much better spot now, but certainly through appropriate research. The Scoliosis Research Society website is also a good reference for that. Surgeons basically, you can kind of find a surgeon through that society. The S.A.S. is the global leader of spine deformity research and education. And again, I'm a proud past president, and Ron's on the board right now, and Serena's the president-elect, so we're obviously partial to that society as well. But if you do your research, talk to other physicians or surgeons, spine surgeons that you meet, I think most surgeons, especially when you have a deformity condition, are pretty honest. If they're not comfortable treating you as a deformity patient, they'll refer you to someone who does. And again, almost all surgeons focus their practice on degenerative conditions, and then some kind of split off and focus more on deformity. And I think it's important to make that distinction. Most degenerative surgeons don't get comfortable with true deformity treatment, and that's why deformity is kind of separated out as to a bit of a subset of that. But it's not a common subset, so there's not as many deformity surgeons, but it's an important component.
Probably because I think complex deformity is the most difficult area in spinal surgery. It is a very complex area, which is why, fortunately, we have experts that focus on it.
Well, it just makes sense. If you're doing a 1 or 2 level fusion, that's different than doing a 15-level fusion. So
Right.
it would make sense to any layperson. That's going to be more complicated surgery potentially. Right? That's the bottom line, because true deformity involves more vertebra of the spine, so it requires more surgical intervention.
And the knowledge to get the balance right. So Serena,
Exactly.
what's your recommendation for finding a spine specialist who can deal with your deformity?
Yeah, so I think Larry's points were perfect. I mean, I think ask other doctors, ask your spine doctor. The S.A.S. for the U.S. includes virtually everybody, or most people that do significant
And the
amounts of
S.A.S.
deformity.
is?
The Scoliosis Research Society, we all belong to. When you have a surgeon who's committed to treating spine deformity, like you mentioned, and wants to continue to learn and perfect that, you want to talk to other spine surgeons that also deal with deformity a lot, because you learn from each other. Everybody doesn't need to do 10,000 cases to learn from those 10,000 cases. You want to learn from everybody else's experience. So I think having that kind of a interaction among people who do spine deformity surgery is really important. And then, definitely get multiple opinions.
Yeah, I was going to say, the good thing is that these are normally not surgical emergencies.
Right.
These are elective surgeries, often necessary elective surgeries, but patients have time not only to find the right person to do the surgery if they elect to go down that route, but also to get themselves in better shape, whatever the process is, to have the surgery. So, do your research, do your homework. Sometimes it's also the best fit of how you feel comfortable with that surgeon, because someone's going to take 7 or 8 hours taking care of your scoliosis. You want to make sure that you feel comfortable with that surgeon taking care of you. It's a big relationship, an important relationship.
I think you made a huge point there, is that the patient has an obligation to do their part to get better and to heal. And so getting your body in shape, getting the right nutrition, doing the right fitness before and after the surgery are essential for that success. And that's a huge point on any spine surgery or any spine problem.
Right.
Ron, your thoughts on finding spine specialists?
In addition to the Scoliosis Research Society and the Spine Health Foundation, organizations that we know are very in tune with this type of surgery, but also patients. Obviously there are many patients who have had spinal deformity surgery. If they've had a good outcome, they're happy to tell you where they got their surgery. Now there's so much information you can find at different centers, and it does make sense to see a few different surgeons. And I always use the adage that if I'm going to buy a pickup truck, I'm not going to go to the first dealership that I see and just spend whatever the ticket price is. I'm going to go to a couple different ones and look at it, evaluate one, get more information, and that's a lot less significant than having a big spinal surgery with 15 or 17 levels that we talked about. There's so much information now about each of us who do this type of surgery. Certainly you want to make sure that they're trained in doing these surgeries, they do them routinely, their centers are able to do it. There are some places where a surgeon may be trained, but maybe the center doesn't do many of them, or the opposite. So I think all those things are incredibly important. And even at this day and this point, insurers have some of this information as well. And so we get referrals sometimes, even from the insurance companies saying, this type of center or this type of surgeon, they do more of these type of procedures. I think all these things are important. There's a lot of information out there, but I think the more you gather, it's better to inform yourself as you seek out someone to do surgery. And like Dr. Lenke brought up, oftentimes we'll see patients who have seen many different surgeons for opinions, which is great. And you're not going to have everyone saying the exact same thing. There are many different ways and abilities to do this, but you really have to be comfortable with the surgeon, because this I look at as a little bit like a marriage. We're married to our patients forever. And so if we think that you're appropriate to get a surgery and you really think you need it, that's going to be a relationship that's going to last the rest of our careers from our standpoint and the rest of your lives, and will affect you and your family moving forward. So I think all those things are important, to look at all these different aspects and really educate yourself as much as possible.
So in closing, I request the three of you to just give a little pearl of advice about spinal health, spinal deformity, spinal anything to the public.
We have to stay in shape. We have to have good nutrition, good watch our weight, have good bone health, watch for osteoporosis, trying to prevent osteoporosis if we can, and live a healthy lifestyle. Obviously, that'll give you the best chance of having a good spine. If you're unfortunately, if you have some type of abnormal spinal curvature or true postural malalignment that turns into a disabling deformity, then bottom line, there is hope. If you basically do your research, find people who know how to take care of you, and if you need surgery, find out if you need surgery if you don't. But if you do need surgery, the good thing is that the results are so much better now than even 10 years ago, that the vast majority of patients, even with a multi-level fusion for deformity, which again is often between 8 and 15 levels, they can still also lead a very normal life. We have patients post-operative that play golf, play tennis, snow ski, water ski, even not only after 1 or 2 level fusions like we were talking about with the spondylolisthesis, but even after major scoliosis surgery. So it's really an exciting future. Obviously, we're not there yet. We're always looking to get better. That's why we're having this conference actually here today in New York City this weekend. We have about 125 surgeons who do spinal deformity, trying to educate ourselves to get better. But things have markedly improved, and will only get better in the future. So the future is bright for patients who are afflicted with spinal deformities.
Excellent. Serena?
We know how to help you get better, so that you can either avoid surgery or be better prepared for surgery. Hopefully you don't need it. But if you do, I think we've gotten a lot safer at doing it, and at hopefully restoring people to normal lives.
Yeah, maybe the only other thing to mention is, in addition to what Dr. Lenke said, is that we also realize a lot of this stuff is genetic. And so if you have a brother or sister or mother or father or a grandparent who has scoliosis or kyphosis or the spondylolisthesis and slippage, or stenosis, which is the pinching of the nerves either in the neck or the low back, you're more apt to potentially have it in your family. And so understand that earlier, get screened when you're in elementary school for spinal deformities and curvatures and things like that, but also know this may be coming down the road, and so understand it earlier, maybe get seen a little bit earlier, and then you can help educate yourself and maybe do some of these rehabilitation things before it becomes a problem. But at least you have an understanding that this may be part of what you have, no different than heart disease or lung disease or other things that we talk about.
It's been a pleasure and an honor to interview you. Rita?
Yeah, no, this has been fantastic. I think we're so lucky and so honored to have your time today, your honest information for patients. We try so hard at the foundation to take the brilliance that's coming out of the scientists and the medical professionals and translate that into information that people can use to make the best treatment decisions for themselves. We've talked a lot about the word alignment today. And in the foundation, we have an infographic that says, curves that align make up your spine. And so, come to the website and take a look at that. rhymes, top fives, and lists of things. And how can we distill very complicated information, make it consumable and easier to understand so that you can make the best decision for yourself along with your doctor? And we cannot do that without the brilliance, healthcare heroes who are taking the best of medical science and putting that into practice every day. And so we're so thankful to you for doing this for us today. So thank you very much.
Thank you.
Thank you.